Good evening. My name is Colleen Livingston, and today I'm going to be talking about two different cases that relate to the objectives we have learned so far in Unit 4. Let's start first by talking about case number 1. A newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. In order to differentiate between whether this is a metabolic disorder based on the urea cycle or one based on beta oxidation, the best diagnostic lab study to obtain would be a urinary acid panel. The urinary acid diagnostic includes testing of the urine and blood for 3 different components of the urea cycle: urine orotate, blood citrulline, and blood arginine. In comparison to beta oxidation, these intermediates are unique to the urea cycle. Urine orotate, as the name suggests, tests for abnormal levels of orotate in the urine. While orotate is primarily involved in pyrimidine synthesis, it is a good indicator of problems in our urea pathway. Carbamyl phosphate formed from ammonium and carbon dioxide with the help of the enzyme carbamyl phosphate synthetase 1 condenses with ornithine in the next reaction and is shuttled out of the mitochondria as citrulline. Carbamyl phosphate is also able to be converted to orotate in pyrimidine synthesis. For this reason, changes in the availability of carbamyl phosphate will affect orotate levels. Blood citrulline will measure plasma citrulline levels. As previously stated, citrulline is formed from the condensation of carbamyl phosphate and ornithine to be shuttled out of the mitochondria and into the cytoplasm to continue the rest of the urea cycle. Changes in blood citrulline would indicate problems upstream with the enzyme ornithine carbamyl transferase or downstream at arginosuccinate synthetase. Finally, blood arginine levels would be affected if its upstream or downstream enzymes involved in the urea cycle were somehow damaged or deficient. Arginine is formed from a reaction with arginosuccinate, and the enzyme arginosuccinate lyase then reacts with arginase to form the end product, urea. After determining what tests we should use, a full blood workup was ordered for this female, and the data shows initial blood ammonia level elevated above the normal range, urine orotic acid levels were markedly elevated above the normal range, and plasma citrulline levels were within normal limits. Given the laboratory findings, it is most likely that the patient is suffering from a genetic deficiency in the enzyme ornithine carbamyl transferase, a condition otherwise known as hyperammonemia type 2. When OTC is absent or malfunctioning, carbamyl phosphate is unable to be converted to citrulline to be shuttled out of the mitochondria. As a result, carbamyl phosphate accumulates and enters pyrimidine synthesis to form orotate. Because of the incomplete cycle, ammonium cannot be catabolized and stays elevated in the blood. For other enzymes involved in the cycle, they are far less likely to cause the same results. While deficiencies in carbamyl phosphate synthetase 1, the first enzyme in the urea cycle pathway, would also lead to hyperammonemia, urine orotate would be low because of the reduced or lack of carbamyl phosphate to enter both the urea cycle and pyrimidine synthesis. Well, that wraps up case number 1. Let's take a look now at case number 2. A 4-day-old infant, patient A, is being followed in the clinic. Her birth weight is 5.9 pounds and the pregnancy and birth were normal. Results from the newborn screening demonstrated elevated phenylalanine levels. A presumptive diagnosis of phenylketonuria or PKU was made, and additional samples were obtained for further analysis. The parents deny a family history of this disease. Then, phenylalanine dietary restriction therapy was initiated, with good response of plasma phenylalanine levels that dropped to within the normal range. Now, before I go any further, I want to describe the mechanism that causes phenylketonuria and its presentation. PKU is an inherited disorder that is characterized by the inability to break down the essential amino acid phenylalanine. Normal catabolism of phenylalanine involves a hydroxylation reaction via the enzyme phenylalanine hydroxylase and its cofactor tetrahydrobiopterin. This results in the synthesis of another amino acid, tyrosine. Genetic disruptions or mutations in the genes encoding either phenylalanine hydroxylase or tetrahydrobiopterin will disrupt the catabolism of phenylalanine, leading it to accumulate and additionally disrupting the synthesis of tyrosine, a normally non-essential amino acid. Tyrosine, as a result, becomes a conditionally essential amino acid and would need to be consumed exogenously in order to keep up with the normal metabolism of this amino acid. In addition to this, buildup of phenylalanine has major effects neurologically and, if untreated, can cause intellectual disability, delayed development, and seizures. Another infant, patient B, is also being evaluated for suspected PKU. Tetrahydrobiopterin loading tests are performed on both patients, and the results are presented in the graph provided. As you can see, after administration of tetrahydrobiopterin, serum phenylalanine levels in patient B significantly decrease, but continue to increase in patient A. Given these results, it is likely that the cause of patient B's phenylketonuria is a deficiency in tetrahydrobiopterin. Upon intake of this cofactor, blood phenylalanine levels decreased, indicating that the catabolic pathway was functioning properly and that dysfunction was present in the cofactor instead of the enzyme. Now, the reverse can be said about patient A. After intake of tetrahydrobiopterin, her blood phenylalanine continued to rise after food consumption, as phenylalanine accumulated due to the block in its catabolic pathway. This would indicate that the source of the PKU in this patient was likely a malfunctioning phenylalanine hydroxylase. That's all I have for today. Thank you for a great semester, and thank you for listening.